Hi everybody, I'm Jacky Edwards and I'm going to talk to you today about the prevention and management of surgical wound complications. As we know, surgical wounds are the most common type of wound that requires NHS care, and that account for about 57%. And surgical wounds are deliberately caused through a surgical incision, and that will either heal by being closed at the time of surgery with sutures or staples or clips, or they need to heal by secondary intention because too much tissue has been lost and the wound edges can't be brought together. And most of them, probably about 90% of them, heal without complications or delay. But where there is a problem, it causes a significant issue for those patients. Around 10 million surgical wounds are created each year, and the number of people having surgery is growing, but so too is the complexity of the operations. We know we've got an aging population, and there are many comorbidities that increase the risk of surgery. The estimation is around 250,000 people undergo high-risk surgery each year. And there's a massive push towards day case surgery post-COVID. And actually the target is around 85% of all surgery being undertaken by day case. And the incidence of surgical wound complications is even more difficult to record because of this day case surgery. And the reality is that there is very little understanding of how many patients have surgical wound complications, and therefore it's often not high on the political agenda, but is having a significant impact on community and primary care workloads. Around 957 to 985 million pounds is the estimated annual cost to the NHS for managing delayed healing in surgical wounds. The amount of total wound expenditure is attributed to surgical wounds of 18.9 to 21.8%, making them the costliest wounds. The rate of dehiscence, which is quite old data, and there is no post-COVID data, is around 0.4 to 41.8, which is obviously quite significant. And then in terms of surgical site infections, it's about 0.4 to 11.3%. But we now know that around 60% of surgical site infections occur post-discharge, suggesting that hospital-based surveillance may underreport the true SSI rate. And it's uncertain, as it's unclear how many surgical wounds have delayed healing. The lack of standardization for post-discharge data collection has resulted in a limited understanding of delayed healing following hospital discharge. And the reality is we really don't know how many surgical wound complications there are. So we're going to look at some surgical wound complications, and these are the ones. There are obviously a lot more surgical wound complications, but for limits on time, we're going to discuss these particular ones. And why is it important? Well, it has a massive impact on patients. Delayed healing, as we know, can impact patients' mental health, physical and social functioning, pain, and potentially lead to long-lasting disability. Multiple theatre episodes, delayed discharge, and hospital readmissions are also factors. There can be increased hospital and community visits, which increases the inability for patients to work and their finances. And ultimately, there can be increased mortality, especially in the presence of infection. And ultimately, it has an impact on increased antimicrobial resistance with increased use of antibiotics and antimicrobials to try and heal these wounds. Prevention, obviously, is really important. And GIRFT have identified that all patients should be screened and optimised at the point of listing for surgery. And that means that all patients, obviously, except those undergoing emergency surgery, must undergo a preoperative assessment to identify and, where possible, correct the precipitating factors before surgery. An objective validated risk assessment tool would be really helpful, but many of them are surgery specific, so can only be used where they are available. There are now 2 programs that really help to pre-optimize patients, and that is an enhanced recovery after surgery, or ERAS program, and that's targeted at reducing any surgical wound complications and should be used for all high-risk patients and considered for all other surgical patients. The other is a new program called prehabilitation, and this is where we try and optimize those patients as much as possible before surgery. So they may have pre-surgery physiotherapy to try and increase their lung capacity. And also, patients should receive education on the likely outcome of the wound to be created and the risk and benefits of the surgery, so they can make an informed decision. And also, the latest evidence has demonstrated that the use of preoperative pathways should also be considered. Other things that we can do preoperatively are obviously follow the NICE guidance for surgical site infection, administer prophylactic antibiotics if indicated, and that's for clean surgery involving a prosthesis, clean contaminated surgery, or contaminated surgery. And obviously, we've known for many years not to remove hair routinely, and if necessary, to do so immediately prior to surgery with an electric clipper. Although preoperative antibiotics are often given as part of bundles to certain patients undergoing specific surgeries, anecdotal evidence suggests that some patients are also given prophylactic antibiotics just in case. They are not usually necessary. Therefore, use of antibiotics need to be considered on a case-by-case basis. Otherwise, we are increasing the risk of antimicrobial resistance. Intraoperatively, there are a number of things that we can do. We can prepare the skin at the surgical site before the incision using an antiseptic preparation. And certainly chlorhexidine has been shown to be more effective than betadine for skin prep. However, there are people now who are developing allergies to chlorhexidine, and also it can sting. Obviously, change gloves or gowns if contaminated, perform wound irrigation at closure, ensure a good surgical technique, and select the correct closure method are all important ways of trying to minimize complications. And then post-operatively, we obviously need to monitor these wounds, especially those in difficult areas such as skin creases, underneath skin folds, things like the groin, where there's a moisture element that could lead to infection. We need to educate our patients to support the wound when coughing, vomiting, sneezing, etc., as many wound dehiscence is caused by those types of actions. And also to help take the strain off the incision, we need to prevent or reduce edema. So there are some good educational materials out there for patients, identifying those pre-surgery risks, and they promote supported self-care, so general health, how they can improve their health, what to look out for in dressings, how to reduce that stress on the incision that I've just mentioned, and what activity levels are acceptable to undertake. In addition, there is also some guidance on signs and symptoms to look out for. So what infection looks like, the colour of the exudate, if there are starting to be any gapes or dehiscences within the wound. And these are information sheets are now available paper or digitally enabled. So there are some surgical procedures that increase risks, and nobody will be surprised to see this list. These include cardiac surgery, including coronary bypass surgery, colon surgery, hip and knee arthroplasty, abdominal and vaginal hysterectomy, vascular repair, including aneurysm repair, thromboendarterectomy, and vein bypass. Obviously, this isn't a comprehensive list of all operations for which patients should receive prophylaxis, but represents those commonly performed for which there is no controversy in the literature. And that these patients should have received antimicrobial prophylaxis for all of these operations. So let's look at some of the early wound complications. Like I say, we're not going to go into these in any great detail, but the obvious ones are post-operative hemorrhage, which is obviously an emergency situation. And the guidance is that we call for help, we lay the patient flat, and we apply a clean or sterile pad, applying direct pressure to the bleeding site until help arrives. Catastrophic dehiscence with exposed viscera and visible internal organs, or what we might term burst abdomen. Again, not something that's commonly seen, but should it happen, need to immediately inform the surgical team, lay the patient flat, keep the organs that are exposed moist to prevent drying out of the viable tissue, and change that every hour until the patient is in theatre. Obviously, it depends where the patient is. If the patient's been discharged from hospital, then rather than calling the surgical team or the GP, I would expect people to be calling 999. As we've said, this is an emergency situation. So for those of you who've never seen a burst abdomen, then this is literally where you see the inside of the intestines on the outside of the skin. And there are a number of different ways that these can be prevented, obviously, thinking about all of that pre-op, trying to get the patient to lose weight, reducing the edema. And also some surgeons may use what we call tension sutures to try and prevent those, because the abdomen is a key area for dehiscence. In terms of intermediate surgical wound complications, then again, the ones that would require immediate treatment are obviously any signs of systemic infection or sepsis. These need to be referred immediately for medical review, and we need to follow the local and NICE guidelines for sepsis. And again, spreading infection or what we call cellulitis, again, they need immediate medical review, but they may consider delaying the antibiotics until microbiology is available, because we don't know what that causative organism is. Again, some more intermediate surgical wound complications. These are all taken from the National Wound Care Strategy surgical wound complication recommendations. And these are slightly longer ones. So these are referred to a surgical team within 24 hours. And again, it's around signs of infection. This is looking at local infection. So things like erythema or discoloration, swelling, pain, pus or heat. And again, they do need an immediate medical review, but it's okay if it's within 24 hours. And again, the other key area is where the dehiscence involves an implant. So whether we've got a prosthesis under there, or a mesh, or a breast implant, or whether there is an exposed implant, you can actually see the material, then these all require, again, immediate medical review. And then the ones that are slightly longer are dehiscence, where we've got new exposed tissue, whether there's a possible suspected sinus or fistula, whether we've got draining seromas and hematomas, or there is enterocutaneous fistula formation. And again, these need reviewing, but we've got that little bit longer to do that. So when we look at surgical wound complications, obviously the types of patients that are managed in hospital or community may be different. And certainly higher risk patients will have a period of hospital stay, and potentially early complications may occur while in hospital. And the most likely ones to occur are surgeon-related factors. So problems with the actual suturing of the wound, and so it can come undone quite easily. And then because they're still in hospital, they can go straight back to theatre. We might potentially see more significant early complications like hemorrhage or catastrophic dehiscence, as we've said. Hematoma or seroma formation may be seen earlier and may be more problematic in terms of continuing to swell. And it's important to observe the closure site regularly for any bleeding or swelling or a lump at the suture closure site, so that you can see if something like a hematoma is forming. And check the closure method. Is it cutting into the skin or through the skin? Again, that can be a problem with how the wound has been closed. In community, you're more likely to see wound infection as it develops around day 4 or 5. So again, heat, discoloration or redness, swelling or pain. Dehiscence is more likely to be related to patient factors, comorbidities. Hematomas and seromas can occur later, and they're often more set, if that makes sense. So it's a blood clot, or it's a jellified piece of plasma. Again, in this situation, because we're not likely to get those catastrophic type dehiscences, then minimum weekly review is needed. Dehiscence usually starts small and then grows, and it usually occurs between day 4 and 9. But again, still need to check for swelling, oozing past day 5, any broken clips or sutures, and obviously any sudden increases in pain. So let's talk a little bit more detail about each of these surgical wound complications. So a seroma is a pocket of clear serous fluid that develops after extensive surgical dissection. It happens because we've disrupted the lymphatic channels, which then leak into a closed space. Diagnosis is purely through clinical examination of the wound, but you can confirm it when necessary by either something like a simple needle aspiration or ultrasound. 90% of seromas will reabsorb within 6 weeks, and you should just leave them alone. But if they're symptomatic, persistent, or infected, then they'll require aspiration and drainage. And antibiotics are only given if infection is suspected. So you can see on the left, that's where the seroma forms. In the middle, you can see an ultrasound showing you that black space, which is where the seroma is. And then use of drains or, as I've said, needle aspiration can be used to try and reduce the size of the seroma. So hematoma is a very similar. They're an abnormal collection of blood. They're due to inadequate intraoperative hemostasis, or they can be seen in patients with who are over anticoagulated or have abnormal clotting. The diagnosis, again, is by clinical examination. So you might start to see bloody wound drainage or an expanding mass. Treatment, again, because the majority of these do resolve themselves, is usually supportive. So we wait for reabsorption if there is small hematoma. But if there are larger hematoma or the rapidly increasing in size, or particularly if it's a neck hematoma post thyroidectomy, it's compromising the airway, or if the hematoma is in a contaminated area and is going to become a problem with infection, then surgical evacuation will be needed. So again, this is just to show you a neck. This is post thyroidectomy. You can see that that is swelling, and they can swell to the degree where they start to compromise airway. This is once that area is reopened. You can see there's a large clot in there, and they found the bleeding vessel. Similarly, some similar types of hematomas, again, showing you when they've finished bleeding and they've clotted off, which is what happens in the majority of the time. So let's look at the main two, surgical site infection and surgical wound dehiscence. So surgical wound dehiscence is a separation of the margins of a closed surgical incision with or without exposure or protrusion of underlying tissue, organs, or implants. And it can be a single separation, or it can be multiple, and it can be the full length of the incision or just part of it. Surgical site infection is an infection related to an operative procedure that occurs at or near the surgical incision within 30 days of the procedure, or if the patient has an implant, within 90 days if there is some prosthetic material in the wound. And surgical wound dehiscence increases the risk of surgical site infection and vice versa. So a dehisced surgical wound may or may not display clinical signs and symptoms of infection, and not all infected or inflamed wounds dehisce. And the national landscape is changing. We're starting to understand that infection can develop in a dehisced wound, that it's not always infection that caused it. And therefore, where infection rates are reported, it may not be clear whether infection occurred before or after dehiscence. And it's a bit like the chicken and the egg. Surgical wound dehiscence is seen as synonymous with SSI, as in it will always happen, but that is definitely not the case. And there are lots of other reasons why surgical wound dehiscence can happen, and we'll talk a bit about those shortly. So surgical site infection occurs after surgery in a part of the body where the surgery took place. It can be superficial and involve the skin only, or it can be a deep SSI and involve tissues under the skin, organs, or the implanted material. And we talk about them in terms of superficial, deep, or organ stroke space. And I explain the difference to you, and it is quite important why we understand that. So here's some examples of various surgical site infections of various surgical site infections. Similarly, very common in C-section patients, and most of you will be aware of that. And if we look at the criteria for defining surgical site infections, this is where we can show where each of those classifications occur. So superficial involves the skin and the subcutaneous tissue only. So it's a relatively easy infection to treat. When we start going down to deep incisional SSI, we start to involve those deep soft tissue, including fascia, muscle, and fat. And so we're starting to get a little bit harder to treat. And obviously, if we start to go into the organ area or space, then these become quite significant infections. So any part of the body deeper than the fascia or muscle layer that was opened or manipulated during the procedure becomes the organ or space. And if that's where the infection starts, then obviously the patient will be systemically very unwell. So we're quite good with SSI. We know there is an issue, and we've been working for many years to work out how we can come up with different ways of tackling SSI and preventing SSI. So you've got NICE guidance, which I've mentioned. We've got the surgical site infection guidance, data and analysis, which collects data on SSI. You've got organisations like One Together who look specifically at SSI. We've got GIRFT who've done surgical site infection audits, and the World Health Organization. So lots of initiatives to tackle SSI, but very few to look at other reasons for surgical wound dehiscence or attempt to tackle surgical wound dehiscence or the wider surgical wound complication issues. There are a number of factors that determine whether a wound will become infected. The first of these is obviously the patient. So that can be that the patient has numerous comorbidities, or they're immunocompromised or immunosuppressed in some way. The virulence factors of the pathogen is just how aggressive that pathogen is, how its ability to replicate. Then there's the vascularity and the health of the tissue being invaded. So that can include local ischemia and systemic shock. And if we've started to get death of tissue, then that's somewhere for bacteria to home in on. So that presence of dead or foreign tissue can massively impact how much or how likely that wound is to become infected. And then obviously there's also that prophylactic antibiotic usage and whether that's been effective and given at the right time. So looking at that patient in a little bit more detail, the sorts of factors that are affecting, as we've already mentioned, things like altered immune response, but as I've said, those comorbidities. So coexistent infection may already be there, may already be colonized, they may have diabetes, they may smoke, they may have poor nutrition, the age, if they're older, they're more likely to get an issue. If they've got a long pre-op stay, they're more likely to get colonized with just routine bacteria that are in the hospital. So a whole range of things that can lead to the patient being more susceptible. And then there are some things that we do, those pre and intraoperative risk factors. And again, these are all in the NICE guidelines, but inappropriate use of antimicrobial prophylaxis. So either not given, as I've said, at the right time, the right dose, or given when it's not required. Infection at a remote site, not treated prior to surgery. So, for example, patient's got a leg ulcer and that's got infected and that's not been picked up prior to surgery. Shaving versus clipping, we've already mentioned. The duration of surgery can have a massive impact. Improper skin prep, so not making that clean, sterile area. Improper surgical team hand antisepsis, so contaminating and not changing gloves or just not doing the appropriate prep beforehand. The environment of the room is really important, and you'll know that in particular surgeries like where prosthesis in orthopedics, they will have a laminar airflow theatre where there is an extremely high air turnover, so that air is getting moved constantly and it's fresh air that's coming in, and it then reduces the risk of contamination from the room itself. Obviously, things like surgical tire and drapes, the asepsis itself, and then the surgical technique, which can also be a problem. Some theatres may have also ultraviolet light to help reduce airborne bacteria and viruses. So I'm not going to linger on this, but we know the signs and symptoms of local wound infection and systemic wound infection. But there are certain challenges in diagnosing infections, particularly in individuals with dark skin tones due to the colour change. So inflammation often is misdiagnosed as infection. Inflammation is normal in a new young wound, and it actually forms part of the healing process, so it needs to happen. And redness, swelling, heat and pain are all signs of inflammation, and inflammation can happen even if the wound is not infected. So they don't go together. Inflammation is just part of the process of healing. Infection occurs when we've got that pathogenic microorganism that enters the body and starts to multiply. Unfortunately, the clinical signs are the same as inflammation. And inflammation will always be present when an infection is present, because, as I've said, it's part of the normal healing process. And the problem, like I said, of assessing inflammation and infection in dark skin tones is that any initial redness that you might see on light skin, so the normal inflammatory process, may not be able to be seen on dark skin, and it may be missed in the initial assessment. And in dark skin tone, changes in colour can run the spectrum from pink, red, purple, and in some cases, it may just be limited to a subtle darkening of the existing skin tone. So when we're assessing these wounds, then professionals should look out for any changes in colour and not just redness when we're assessing those dark skin tones. And recognising and being able to differentiate between inflammation and local infection is important to avoid that overuse of antibiotics or antimicrobial topical treatments. And as we've said, those darker skin tones may be more difficult to assess. So what about swabs? We could just swab everything and then we'll know what there is, and that will give us the answer. Well, really, we should only swab a wound when we're fairly clinically certain that there is infection there. Because unfortunately, just because bacteria are present, i.e. contamination, does not mean they are the causative organism in infection. So if we just swab anyway, because we think it might become infected, the results are going to be misleading. We're going to find bacteria. There is bacteria on the skin, but is actually that bacteria the one that's causing the problem? So treatment, obviously some immediate actions would be discharging fluid, if there is any, should be sent for gram staining and culturing sensitivity. And if it's a deep or organ space, we would start broad spectrum antibiotics immediately until the cultures were back. But depending on the depth of the wound, the infection will depend on the treatment. So if we've just got a superficial infection, then we can treat that with topical antimicrobials and probably don't need to go to antibiotics. But as I've said, if we start to look at deeper infection or organ or space, then the action depends on the severity and the timing. So it might be, because they're still in hospital, that they could go to theatre and they could have some sort of surgical intervention like a washout, open it up, debride it thoroughly, and then if it's appropriate, close it or leave it open to be managed like an open wound. If it's not organ or space, it's always better to debride than to wait for antibiotics to act. And as I said, if you can wait, so if it is more of a superficial infection, then it's better to wait till you've got your cultures back so that you know exactly what you're treating. So let's talk a little bit about surgical wound dehiscence. So surgical wound dehiscence is the disruption of any or all of the layers in a wound. And it can occur in up to 3% of abdominal wounds. And obviously, it's quite distressing for the patient. Wound dehiscence, as I've already said, occurs most commonly between the 5th and 8th post-operative day when the strength of the wound is at its weakest. And the patient will often have felt a popping sensation during either straining, coughing, sneezing, etc. And most patients will need to return to the operating theatre for resuturing. However, if the patient's at home and it's a small dehiscence, you may just monitor it and treat it. If it's a larger dehiscence, but the patient's not well enough to go back to theatre, maybe, you might just treat it with dressings like a cavity or open wound, or you might use negative pressure wound therapy. So why do they dehisce? Well, I could say it's not always infection. Of course, it can be, but often it's a technical issue with the closure of the incision. So the incisional closure fails, or it's not strong enough to hold the edges and sides of the incision together. Suture knots can slip, or they can unravel, or they can break, or they can be stretched, or they can cut through the tissue at the side if they've not been placed far enough away from the edge of the wound. If they're too far apart within the wound itself, they're not given enough support. Or if it's put under too much tension. So either by edema or, as I've said, by the patient actually applying a mechanical force on it by coughing, etc. So the other way is by mechanical stress, and it's due to excessive force tension, either during wound closure or of swelling of the tissues around the incision. Commonly happens this way in lower limb legs through edema. So following surgery for lower limb trauma or coronary artery bypass grafts, it's very common. It's also common in patients with cardiac failure who are critically ill and in fluid overload. So again, it's that edema that's causing that mechanical stress. It can also be due to a hematoma or seroma that we've already mentioned. And sudden increase in intra-abdominal or intrathoracic pressure. So as I've said, retching, vomiting, coughing, sneezing, and also lifting heavy weights can also contribute. There also can be just disrupted healing, and that can be due to both local and systemic factors. And we're all very familiar with these. There are a number of both local and systemic factors that disrupt the healing of a closed surgical incision. And it can occur for multiple of these reasons. The patient may have multiple issues going on at the same time, and it can occur at any phase of healing. And as I said, you can either have local or systemic. So local factors might be hypoxia or death of the tissue, might be infection, might be inflammatory conditions, might be stress or trauma, etc., hematoma. And then the systemic factors are those that we've already talked about. So age, chronic disease, comorbidities, smoking, malnutrition, etc. So there are a whole range of different reasons why that wound may not progress in the way that it should. So let's look at the signs of surgical wound dehiscence. So inflammation beyond the time of normal healing. So if your patient is still showing redness, heat, etc., beyond day 5, then it's likely that wound's going to dehisce. So swelling, edema, seroma, redness, bleeding. Opposed suture margins are open or separated at any point along the incision. So if there's just a tiny gap, then and the wound's not in close opposition, then that wound's going to fail, and that may lead to dehiscence. If you can see broken sutures or clips, that's a massive indication, and increased pain at the incision site when it should really be reducing at that stage of wound healing are all good signs. And again, if it's darker skin tones, you need to look for colour change compared to their normal skin. And this is taken from the World Union of Wound Healing surgical wound dehiscence document, because that's the most up-to-date we've got. And you can see they break down the risk factors into major, moderate, minor, or rare, and when that's likely to happen. So how do we assess these wounds? Assessment's really important. We know that. Holistic assessment, extremely important. We need to assess the whole patient. So particular importance is events leading up to the dehiscence, vomiting, coughing, etc. And we need to record a whole range of factors. Unfortunately, in the Coleman minimum wound data set, these are not in there. So a lot of these are not recorded at all. And in most wound assessment charts that now exist within the UK that are based on that generic wound assessment data set, they're not there. So things like the type of surgery, the timing of surgery, whether it is emergency or elective, which massively makes a difference, the closure material, the date of removal of that closure material that's expected, the classification, the drains, whether there is a prosthesis or implants, whether the wounds were approximated or not, whether there's crepitus, a healing ridge, or a fluid connection between the wound closure and any dehiscence. They're just not able to be recorded on the current minimum data set. So there is a new surgical wound minimum data set available on future NHS as part of our legacy for National Wound Care Strategy Programme. It's really important we assess each dehiscence individually. They can be through very different layers of skin. Some dehiscence could be infected, some may not be. And you might want to think about a grading tool that will help clinicians understand and describe what they're seeing. But there is very little training exists for assessing surgical wound complications. And there is a culture of thinking now that surgical wound dehiscence is normal. A little bit of it, it's normal. We see it so often now that we don't think about it and we're quite blasé about it. So again, there are now training modules in the National Wound Care Strategy on e-learning for health on surgical wound assessment. So in terms of grading tools, there's the Sandy wound grading tool and the Time one that's been converted. Again, some clinicians like to use grading tools and find them helpful. Some people don't. So it's just to say that there is an option if you wanted to use one. Surgical wound dehiscence is potentially very frightening for the patient. So reassurance, management of expectations, and education of the patient as to what's happening is really important. Pain management is extremely important. Obviously, this is a new trauma to the wound. It will be accompanied by pain, and we need to make sure that we look at that. Removal or reduction of risk factors that have contributed to surgical wound dehiscence, really important. It could be as simple as a chest infection and the patient is coughing way more than they would have been normally, and they've not been supporting that wound, and that's what's led to it. So if we treat that chest infection, things will improve. It can be poor blood glucose management, it can be smoking, it could be nutrition, it could be a whole host of other things that could be. And then again, local wound management of dehisced wound really depends on the severity, so the depth of it, what is exposed, what's actually in the tissue, what can you see, is it viscera, is it bone, is it implant? It can be the presence of infection, and again, is it superficial infection, deep or space or organ? The timing, so is it happened just after surgery, and could that wound be resutured? Are they still in hospital? Could that happen quickly? And then obviously the presence of other comorbidities that will increase the risk of surgical wound complications or impair healing, as we've already said. So let's have a little look at a case study. And I will say up front, this is not my case study, but I am using it as an illustrative example. So Flaminol, and I'm presuming you're listening because you want to hear about Flaminol or you already use Flaminol. It has multiple modes of action and avoids the need for multiple products, and is suitable for a variety of wounds and tissue types and ages of patients. It works as a debriding gel, continuously debriding the wound. It absorbs exudate because it's got an alginate within it. and it's antimicrobial as it's got this enzyme system which offers antimicrobial protection and reduces bacteria released from biofilm. So this is a case study of a 1-year-old female infant born at term in November 2019. She was born with her intestines, liver, spleen, and some of her stomach outside of her abdomen. Surgery was performed in October 2020 for abdominal wall closure and Biodesign patch, and a graft intended for, which is a graft intended for implantation to reinforce soft tissue where weakness exists. And you'll hear them called patches or mesh or other names, but they reinforce that abdominal wall. The infant attended the ED in December 2020, 2 months after the surgery, with a dehisced surgical wound measuring 5 centimetres in length, 3.5 centimetres wide, and had a depth of 0.5 centimetre. She was seen and obviously treated initially with intravenous antibiotics alongside fluids, as the patient was pyrexial, tachycardic, and there was purulent exudate, so effectively treated for sepsis. Wound care was decontamination and with solution soaks, and then Flaminol Forte and silicone secondary foam was applied. And initially this was on alternate days. So the figure 2 you can see is the wound during treatment, just a few days after initiation, and already the wound is looking a little bit better. On the 13th of January, you can see there is slough is nearly now completely gone. The peri-wound skin has significantly improved, and the wound bed is now much more visible. It's showing healthy granulation tissue with some epithelialization and quite a significant reduction in size. This Flaminol Forte regime was continued for 4.5 months. There was no further episodes of infection during that time, and the patient was able to be managed completely at home. And its non-toxic antimicrobial components permits Flaminol to be used indefinitely through that trajectory of healing. So you can see on figure 4, the wound is absolutely massively reduced with just some healthy tissue present. And then in figure 5, it's almost healed. It did go on to require another 4 weeks, but that was just really small areas that just needed some protective covering. And the wound was fully healed in April 2021. So you can see a really nice case study of how Flaminol can help, particularly in that very young age group where you may not be able to use other products. So what are the wider implications of surgical wound complications? Well, certainly issues with antimicrobial resistance, which I'll expand on a little more. We've already mentioned this impact on community workload, and when I speak to community staff now, surgical wound complications are making up the majority of their workload. As I've said, there's been a lack of education, which hopefully now there is some around, a lack of assessment tools, and one of the things we've just developed is a clinical decision tool, which is also available on Futures NHS. They have financial implications. So obviously for patients, if their wounds are taking much longer to heal, they can't get back to work, they can't commence doing lifting, etc. They've got multiple clinic visits, costs of dressings, you know, those financial implications become significant for the patient. And there are problems with inadequate pathways back to the surgical team, which again, we have developed a pathway for that through the National Wound Care Strategy Programme. So let's look a little bit more about this issue of antimicrobial resistance, because it is significant how much surgical wound complications are starting to impact that. So we've got increased antibiotic use, including misuse and overuse, and that can cause bacteria to develop resistant mechanisms to survive and proliferate. That leads to prolonged hospital stays, but that exposes the patient then to more hospital-acquired infections and more resistant bacteria. Potential inadequate infection control practices and cross-contamination of equipment can lead to transfer resistant pathogens between patients. And that's always one of the things that happens if you get a patient in a ward or 2 or 3 patients with a similar bacteria, then they will start typing that because they need to know whether it is cross-contamination or whether it's been brought in with the patient. Biofilm formation in surgical wounds that are infected can cause these persistent infections. It leads to more prolonged antibiotic treatment or topical antimicrobials, and that all impacts on the development of antimicrobial resistance. And then potential invasive procedures like abscess drainage, hematoma, seroma drainage, all of those increase the risk of resistant bacteria entering the wound. So you can see there really is it's almost like a perfect storm when you've got a patient with a surgical wound complication that can lead to this increase in antimicrobial resistance. So in summary, not all surgical wounds dehiscence is caused by infection. The majority of surgical wound complications occur post-discharge. We know that surgical wound complications are underreported because the reporting systems are only designed for hospital. The volume is increasing, impacting on community workload. Education is needed to make staff aware of the signs and symptoms to promote early intervention, because we know that early intervention means that wound's going to heal and hopefully will reduce that severity. We need to improve our pathways back to the surgical team, and we've identified how surgical wound complications can contribute to the development of antimicrobial resistance. There's some references which when you watching this you should be able to see, and thank you very much for your attention, and if anyone has any questions I'll take those now. Thank you. So hello everybody. We've had a couple of questions in the chat, so I'm going to address one of the first one of those. The first one is from Norma Sargent, and she said, "Hi, we see a lot of abscesses, recurrent perianal, and we're told daily packing for 1 week. Any advice? A recent scrotal abscess took 10 weeks to heal." There's a study that came out in 2022 looking very specifically at perianal abscesses, and they have identified that there is no need to pack. Obviously, the wound would be packed in theatre, and that would be to promote hemostasis and stop any bleeding. But after that, the wounds don't need to be packed. There is, like I say, there's a really nice, easy to read study that I've asked the guys to put in the chat, so you can have that link to that study. And though, interestingly, Katie Newton, who's a surgeon who was the lead in the study, presented at Society of Tissue Viability last week with an overview of the study, and that may be on playback, but it's very clear that there is no advantage to packing, and obviously from a pain point of view it's extremely painful to do for patients, and obviously from an input and a workload point of view, packing daily is going to have a massive impact on workload. The patients in the PAC2 study were all able to self-care, because most of them are young, fit adults that have a problem with perianal abscesses. So I hope that and the link covers that for you. I've then got a question on what is the best way to monitor wounds between dressing changes or signs to ask patients to look out for. I think obviously any changes from normal, so if you're looking for surgical site infection, you're looking for those signs of infection, so heat, changing skin coloration, pain. Those are sort of the things that you would be advocating the patient to look out for. In terms of surgical wound dehiscence, you're looking for any small strains in the sutures, any breaks in sutures, again, any inflammation or change in colour. Often surgical wound dehiscence is associated with quite an increase in pain, and often the patient will feel that popping sensation. And there are some really good patient information leaflets on exactly that and what for the patients on signs to look out for, and they're available from the ongoing National Wound Care Strategy NHS Futures website called Improving Wound Care. So again, we can pop that link into the chat. I'm just scrolling down to look at some. So, are biofilms likely to be a problem with surgical wounds? If your wound follows the normal progression and doesn't have a problem and heals, as most of these wounds do, then there really shouldn't be a biofilm problem. But like all wounds, if they are left open, or they're open for, they're not closing normally, or they've dehisced, or they've been deliberately left open to heal by secondary intention, then yes, those wounds do start to become affected by biofilms, in no different to any other wound type that has gone past its normal stage of healing. You will get resident bacteria that start to form the colonies, and they will start to form biofilm. So definitely they can be a problem in surgical wounds, but it's in those wounds that have developed a surgical wound complication rather than those wounds that are straightforward and go on to heal. So question 4 is, do you use aseptic technique post 2-week limb arthroplasty? THR stroke TKR. I'll have to tell you, I'm not quite certain what those acronyms are. For clip removal, as in our clinic, we sent these patients without any dressing. I think if you have a sealed wound, the wound has progressed normally, and there are no signs of wound dehiscence, then there isn't a need to do an aseptic technique. That wound is effectively healed and it's sealed. So if you are removing clips, it's, I think it's down to local practice. Some people will use an aseptic technique, some people won't. I think it depends on whether you're looking at the wound and you think there's going to be a problem when you take those clips out. Then if that's the case, then I would definitely think about using an aseptic technique if you think there are going to become some small opened dehiscences within that once those come out. But I think when if it's a straightforward wound and it's progressed and it's healed, and you just literally taken the clips out and the wound will remain healed, then again, down to local practice, but maybe you might not use an aseptic technique in that. So I think that's really a local question that you need to see what your tissue viability team feel about that. I've got a question on where can I access assessment templates? I'm not quite certain which assessment templates you mean. Are you meaning assessment in terms of the clinical decision template that we've just recently published, or are you meaning assessment of a surgical wound template? Because that at the moment doesn't exist. That's part of the development of the surgical wound minimum data set. Again, that's on NHS Futures, and I will make sure we pop the link to NHS Futures in the chat where you can get access to all of those things that I've talked about. But you would create your own template from that minimum wound data set so that it fitted within your own clinical practice. I can't see any more questions. Are there any more? Oh. How long can we keep the tube once it's opened? I have to say, I don't know the answer to that question. Because when I use it, when my clinical practice is burns, we use the whole lot, so we've never got any left. But it certainly doesn't have contraindications. It's probably one of the most inert types of dressings. It can be used on neonates, which many others can't. So I'm not aware of any specific contraindications. There may be areas where you decide it's perhaps not the right dressing to use, and I've just been discussing this with some of my clinical colleagues yesterday, and they were saying, if it was a really massive wound, they might not put Flaminol in, but if it's a small cavity, then they would. So like I say, I'm not quite exactly certain about the length of time you can keep the tube, because like I say, I tend to use the lot all in one go, but certainly no contraindications. Question 7 is, can we use Flaminol on trauma wounds or any skin flap or tear? Yes, you can, definitely. There are no contraindications to doing that. It would be extremely controlling pain for the patient. We use it in burns a lot because of the pain issues. So it works really well for that type of traumatic wound. Question 8 is, are there any extra precautions to take for higher risk patients with comorbidities to prevent surgical wound complications? Yeah, those higher risk patients certainly need to have quite a very specific preoperative pathway. They need to be looked at in terms of the oh, my brain's gone. Oh, sorry, blip. Trying to think of the word there. Yes, we need to look at what we can do beforehand, so prehabilitation. So can we get these patients a little bit fitter than they are, a little bit less heavy than they are? Can we get them to give up the smoking? So a lot of different surgeries have taken up the prehabilitation issue, and particular cardiothoracics as an example. And then we can also look at enhanced recovery programs. So again, we know these patients are a high risk. We know that they may have a more complex and more systemic complications that may lead to them being in intensive care. So we can, again, think about putting those through that enhanced recovery program, because we're aware that they're more high risk, and we should have them in the right location, i.e. HDU or ICU, so that if those complications do occur, we can again address them early. It's all about early intervention. So I hope I've answered that. Question 9 is, hi, we are about to embark on a rub, don't scrub campaign within theatres in accordance with the V2 intercollegiate paper. Are you aware of any research identifying increased or decreased SSIs linked to change in scrub practice? No, and it is something I've looked at before. There is nothing that has come out specifically about that. I'm sure it's an area of research that people will start to look at, because it's certainly something that is being discussed quite widely at the moment, but nothing that I've come across that. The next question is, can you elaborate more on the chlorhexidine betadine issue? Is there much research, and how should the Clorox be used? Do we dilute? I know that that the evidence and the literature suggests chlorhexidine above betadine, certainly. I don't know the dilution. I think that's down to individual practice. But certainly the evidence is there that chlorhexidine seems to be more effective, particularly since it's become a modified chlorhexidine from what we used to have many years ago. However, there still can be allergies, as there can be to anything. And obviously, depending on the dilution, does depend on how stingy that is post-operatively, and patients can feel it. So again, that's more of a local practice, I think. Question 11 is Flaminol all right to combine underneath Aquacel dressings or ordinary dressings like Tegaderm or Clear Pearl? It certainly often has a secondary dressing, although again, we talked about yesterday with some of my clinical colleagues about times when we might not put a dressing on, but it's certainly okay to have a secondary dressing over the top, and certainly when we use it in burns, that is what we do. I'm not sure underneath Aquacel might be the best thing, but certainly things like Tegaderm over the top, or a foam or something like that. I would have thought the Aquacel may absorb it a little bit and maybe make it less effective. I don't know, because it's not something I've personally tried. But it's certainly, yes, that it's used widely without any of the any dressings over the top, in certainly like burnt faces and different areas on the body, but most people do use it underneath a secondary dressing of any type. That was the last question. Okay, well, I hope that's been useful. I will just pop in the chat for you the NHS futures, and hopefully that has been really useful.